All right, let's get started for today. Good afternoon. I hope that you all had a good weekend. We are back for week number 2 of Communicating Health and Science. We spent some time last week going over the general overview of what health and science communications are and some of the ways these things are important and potentially connected to the work that you all might be doing in your lives, in your other classes, and so on. I also recognize some of the chuckling and fingers at this point in the quarter that there are some new faces here for today. So I'm going to ask that folks that are here for the first time do a short introduction. When we had our first day last week, I asked folks who were visiting for the first time to tell us their name, what got them interested in taking this class, and then how they would describe their experiences working with healthcare providers. Is it a good experience, a bad experience, somewhere in between, and so on. So with that information in mind, quick introduction, why you're taking this class and what your experiences in communicating about healthcare have looked like. Is there anybody here for the first time who wants to start us out? Yeah.
Hi guys, my name is Izzy, and I took this class because a few months ago I was offered a job as a behavioral health intern. So it would be a lot of like working with public health and like drug and alcohol prevention. I didn't feel prepared enough for that, so I didn't take the job. But in case something was ever happen like that again, I wanted to be prepared.
Yeah.
And then my experience with public health would probably just be like, I'm from a small town, so like when you go to doctor's appointments and you have like someone you know as your doctor, that can always come across a professional line or you think personally. And I feel like that's the balance and something with each other.
Awesome. Thanks, Izzy. You know, as you brought up, right, having a skill set to talk about and sort of work in that type of field is really important. We'll kind of hit on some of those things from a communication perspective. And also, as you brought up, right, some of the challenges in communicating about healthcare based on location, morality, and all of that are really important considerations too. We're glad to have you here, and thanks for taking the time to tell us a little bit about yourself. We've got a couple other folks. Yes.
My name is Macy. So I feel like it's just a beneficial topic for like having information on some of that. And then I think like just learning how to be a better advocate for myself if I ever have to like go to the doctor. I think it's just good to know.
Yeah.
And then I'd say my experience with health providers in the past has always been good, and I'm lucky that it's been good because I've had a lot of bad experiences.
Yeah, awesome. Glad to have you here, Macy. I appreciate you sharing some kind of the background that you're thinking of heading in. And, you know, it sounds like a lot of people have had fairly positive experiences, but have also heard like not so great stories from others. So we'll be talking a little bit about that. And also talking about how you mentioned the ways that we can advocate about or be in a good position when we're communicating with providers, right? To feel like we're better able to have our concerns being heard appropriately. So I appreciate you bringing that to the table.
Patrick, and I chose this class because I'm going into health education and program planning. And I think it's really important because I work at RISE, which is healthcare caretaker for people with disabilities. And I've seen like firsthand how important it is to have a good communication with clients. You know, when developing their own ISPs and things like that.
Awesome. Yeah. You know, and having that kind of on the ground experience already in that caretaker role, right? It's a challenge to figure out how to be supportive, how to advocate, how to manage the boundaries and issues that might be impacting the folks that you work with, right? So it's an important relationship and kind of tightrope to have to walk. And it's interesting to have folks who've had experience on kind of both ends, whether you're a patient or somebody that's providing some type of care. Yes.
And I'm just interested in stuff because it's going to change my
Welcome to the dark side.
and I just thought this would be an interesting class. And I usually don't have a really good experience with healthcare, but my sister's a nurse, so I usually just go with her all the time.
Oh, yeah.
Probably why I have an experience.
Yeah.
But yeah.
Yeah, I'm curious who else has had like family or relatives who are involved in healthcare related fields. Yes. so a few of you. It's interesting when that perspective gets added in and you like talk to people who come from that expertise. Again, I came from a family of therapists, so they had a kind of clinical way of describing care, kind of in a different way, right? That there were ways that you start to pick up on language and practices over time. So, as a comm major, it seems like there will be some good connections there too. So I'm glad to have the new folks here in the class. Again, I'm really excited to teach this course. It's the first time this is offered here at EOU. We're hoping to put it on regular rotation. So if you were not here last week, if you haven't done so already, I recommend checking out the recordings and slides for last week's classes, and also making sure to complete the week 1 quiz if you haven't done so already. Generally speaking, if you have 3 or fewer absences, then you don't need to do anything. But if you have more than 3, I'll ask you to complete a little makeup assignment that's on Canvas that just covers content from that class. We don't have a whole lot of class meetings. In fact, we're at like less than 20 overall since we meet twice a week. So just know that as we're working through stuff in the class, that those resources are available for you. Glad to have you here. So as a quick recap, we spent some time last week talking about health and science communication, including some of the different approaches that people can take. For instance, we contrasted the biomedical approach with the biopsychosocial. When we were defining and explaining what health was last week, we dealt with the idea that health is not just physical, right? You don't just come to a doctor when you have a cut. Health is about an array of physical, mental, and emotional well-being that impacts who we are. And then the definition of what we can consider health or healthy could look very different depending on culture and context, right? For many members of the deaf community, they might consider themselves healthy and don't necessarily seek out something like a cochlear implant. We talked about some of the history and context related to health and science communication issues, right? Kind of the older styles of doing health up through the Industrial Revolution, the development of the modern model that we see with things like health insurance and so on. We also talked about indigenous and First Nation approaches to healthcare as well, and the ways in which the changes in European colonization has impacted indigenous healthcare. And we looked at some issues and current events. I asked people to brainstorm and talk about related topics in health, communication, and related issues. So for folks that are talking or are here in this class meeting me for the first time, I'm an assistant professor of communication at EOU. I do health, science communication, rhetoric, and all of that fun stuff. So with that being said, is there anybody who was here last week who wants to take a stab at defining what health communication is? Take a moment to look back through your notes or refresh yourself a little bit. Yes. Yes. So the way that we seek, process, and share health information, right? So health communication could involve, right, if we find that we've been just diagnosed with a condition that we have no awareness of prior or haven't thought about in our own lives, right? For instance, maybe you were diagnosed with ADHD. And you know a few things, like some stereotypes or maybe a couple friends, but you want to learn a little bit about it. You would seek out that information, right? But health communication is also about how we use and share. So toward the end of the course, we'll be talking about health campaigns, right, or larger public efforts to share information about health. We'll be talking about how health information is shared with the public. And we'll talk about, for this week in particular, how health communication is conveyed between like healthcare expert and patient. What about science communication? What is science communication? Go for it.
So we use the acronym EIOU
Mhm.
to describe science communication. So awareness and familiarity with science, enjoyment or appreciation of science,
health and science and the way that it's communicated, opinions that form and develop related to scientific attitudes, understanding science and its social factors.
Yeah, thanks, Angelin. So it's actually just about to bring that AEIOU example up. So science communication is very similar, but it's concerned with how information about science is shared, utilized, circulated, and so on, right? For those of you, sounds like just about everybody has taken a class of communication before, right? We talked about communication being interpersonal between two people. We talk about it being public, meant for a larger audience. We talk about the use of mass media, for instance, a public campaign or effort, for instance, information that's shared through the CDC, are examples of how we circulate and convey information. These things, of course, are pretty deeply intertwined and connected to each other. So for this class, and this week in general, right, our focus is going to be on patient-provider communication. That's going to be pretty interpersonally focused, although it's also small group focused in that patient-provider communication might involve something like a team. For instance, particularly with people who might navigate challenging diseases or experiences, a lot of times something like a healthcare team is developed to create a collaborative environment for people to address and deal with a major health issue that comes up. So we'll talk a little bit about patient-provider communication, mostly going over the things in chapter 3 of your textbook, and then we'll move on to 4 and 5 for Wednesday, and start to understand some of the patient perspectives and what it is that people want out of that healthcare experience. Before we do that, though, I do want to take a moment to tell you a little bit about your first assignment for the course, which is an annotated bibliography assignment. This assignment is due in 2 weeks, so it's due on Sunday, April 17th. Like I mentioned on our first day of class, if for any reason you need an extension, like you're running behind, something's come up, let me know, and let me know when you think would be a reasonable time to turn it in. Generally speaking, if you let me know about a week ahead of time, you're good to go. So I definitely recommend looking at that date. And if you've got a bunch of other assignments or exams coming up, let me know so that I can help you out. I'm going to go over the rubric in just a second, but it's on Canvas and it goes over the things that I'm looking for. And what I'm asking you to do for this assignment is to pick, and the sky's the limit, right? To pick a topic or issue that interests you related to health or science communication that you want to learn a little bit more about, right? So a lot of you are coming into this class for different reasons or have some different specific interests, or maybe you're just kind of curious and getting your feet wet in this area. So there's a lot of different things that you can start to look at. For example, maybe you're really interested in understanding COVID-19 from a health and science communication perspective. As you can probably imagine, there are a ton of articles out there, and many that are being published and reviewed as we speak. They're talking about COVID-19, whether it's about the ways that information is shared to the public, maybe it's about issues of information, misinformation, campaign, so on. So there's a lot here about COVID-19 and the way that it's communicated. So that's an area to go. Some of you might be interested in like sports medicine, athletic medicine, and similar related fields. Similarly, there are a lot of connections between sports, athletics, and similar types of approaches to health and communication. Another example, right, is terminal illness. For instance, there's a lot of risk in cancer health communication research out there. There's some really cool work, for instance, from Dr. Kim Finks at my previous institution, did work analyzing how mothers and daughters communicated following a breast cancer diagnosis, right? So there's some really interesting and focused work on things related to illness and specific conditions, if that's an area that interests you a little bit more too, right? So, you don't necessarily have to pick a topic that you're going to be stuck with for the whole course or anything like that. Think about that as a chance to explore, right? The two major journals that I would really recommend looking at are Health Communication, right, which itself is a journal. And second is the Journal of Health Communication. It's actually a separate journal. So you got Health Communication, Journal of Health Communication, two separate journals, two separate editorial boards and staff. But each journal does some really cool work related to current research in health communication and related issues. And that's a great starting point if you find yourself interested in learning and seeking out a little bit more. So, for instance, if you do a Google search for health communication, first result is the actual journal that comes up here. You can check out some of the latest articles, right? So for instance, COVID-19, right? Obviously, discussion about vaccination, decisions to vaccinate or not. A lot of stuff about vaccine hesitancy. Also, right, interesting discussions in health communication related fields surrounding breastfeeding and some of the challenges of like public disclosure of doing so. So there's a lot of kind of interesting work here. Fitness, health, and that relationship is interesting. Sexual health, right, and all of that, depiction of health in media. So you can start to look through some of these things to see articles that might stand out or be especially interesting to you. Similarly, you can do so for Journal of Health Communication. So smoking and depiction of smoking in media, HPV vaccination, right? A lot of interesting stuff here. And again, a lot of stuff related to COVID-19 that's been circulated and so on. Another thing that I recommend, right, is the use of Google Scholar. If you haven't done a search already, you just go to scholar.google.com. I got it wrong, didn't I? Right, and I would recommend like health or science communication followed by the thing that you're interested in learning about. So like health communication and disability, right? So there's a lot of discussion about how health communication and so on is conveyed or shared with folks with disabilities, right? So a lot of different options there, whether it's looking at those specific journals or just doing things like Google Scholar searches, JSTOR, right? If you haven't done so, jstor.org is a great resource that we offer here at EOU. You can access it through the EOU library. It has a lot of articles that you can find on related fields. But really, right, instead of seeing this as like a big, scary assignment or project, this is a chance for you to explore, right? To find topics that you might be interested in or want to learn a little bit more about and to explore. Again, I posted those there. JSTOR also has a text analyzer feature, which allows you to enter in essentially like paragraphs or content, and it finds articles that match those keywords. So it's pretty cool. And then I've also posted an example of an annotation for this assignment so that you know what I'm expecting there. I'm asking you to use a full citation in APA, MLA, or Chicago. I personally use APA the most, one I'm the most comfortable with. However, you could use MLA or Chicago if you use it for your other classes or before or more comfortable with that format. All I ask is that you stick to whatever format you choose to use rather than like a mashup or kind of MLA or kind of APA, right? Focus on mastering the format you feel good about. And then making sure that in the annotation you're describing this article and its contributions to your topic in your own words, right? Rather than like a word for word regurgitation of the content that's already in the article. So if you check on Canvas, I've posted a couple things. First of all, if you scroll down to the third week, you'll notice that the annotated bibliography is listed here. I'm asking you to identify 5 to 7 outside sources related to the topic that you've chosen. Again, your topic can be pretty broad using those examples that I shared earlier. and then including a short paragraph for each of those. I don't have a page limit for this one since it can fluctuate a lot depending on the amount that you do, but I would recommend, good like 5 to 7 sentences for each source, like a good paragraph or so is an easy way to do it. It doesn't need to be threaded together like an essay. It can just be here's the source, and then here's my annotation, and just working through that way. The criteria for the rubric that I'm using here, first of all, are the citations, right? Including full citations, that have all you need for the source. If you're a little bit iffy about how to cite sources, I recommend using the Purdue OWL, which is a great database that includes full website information about how to use each citation style. You can also use like a citation maker or citation machine. The caution that I would give you about doing that, though, is if you're just directly copy pasting, one, you're going to get some weird formatting stuff like the font color changes, the highlight, and so on. I recommend pasting without formatting. The other thing is that if you're using a citation maker or a citation machine to cite source, oftentimes it will not autofill everything. Sometimes things like the page numbers or years are missing. So fill in the things that are not included. And then next, I'm looking at the annotation, right? A good response here uses a paragraph to describe how this thing connects to health communication. Also, right, that you're choosing good quality articles, for instance, book chapters or published pieces from journals like the ones that I recommended are good ways to start. And then making sure that you have good organization and structure for this assignment is important too. I'll also mention there's also a journal titled Science Communication. That is another one that's a really good one to look at for this class too. So similarly, has a lot about the way that podcasts are being used to share information about science. Again, stuff surrounding COVID-19, risk communication, immigration, migrant workers. So there's a lot of content that you could draw from in that journal too. And then I will look at rough drafts or outlines if you send them to me in advance. I'm happy to give you feedback on those, let you know if you're on the right track. Before we get started on some of the new stuff for today, are there any questions regarding the annotated bibliography or any questions about the course? Questions do come up at any point, please flag me down and let me know. All right. So what I'm going to do is divide us in half into 2 different teams. And for this week, we're focusing on patient-provider communication, right? So what does it mean to be a person that is seeking out healthcare or services? We've been in those shoes a lot. And some of you have been on the other side, right? Have been in the role of being somebody that provides healthcare or provides services. Oftentimes we experience frustration when we feel like something is lost, or we feel like there's a lack of respect or concern across either of those sides, right? Folks like Macy have brought up having friends or people they know who have had negative experiences. And so what I really want to drive home for this week is this idea that good patient-provider communication is a relationship that we're constantly building and developing over time, right? So Candace is going to see a general health doctor because she's had severe headaches for the last 24 hours, right? And then what I'm going to ask each team to do is to first, one team will focus from Candace's perspective and think about and start to develop what they believe are the 5 most important things that need to happen for Candace to have a successful visit, right? So what's necessary for that experience to be a good one for Candace? And then I'll ask the other team to think about it from the doctor's perspective. What are the 5 things that need to happen for them for Candace to have a successful visit? I'll give each team about 10 minutes to talk and to develop their list of 5 important things. And then I'll ask each of the teams to share. So it looks like we've got 3, 4, 5, 6, 7, 8, 9, 10, 12. Perfect. So we'll do 1, 2, 3, 4, 5, and 6. You all will be the team number 1. So please find a place to talk and chat together to come up with your list. We'll have 1, 2, 3, 4, 5, 6, and 7. It'll be team number 2. We'll be focusing on the doctor's perspective. So again, each team will get about 10 minutes to develop their list of 5 things that need to happen in that visit from their perspective. And then I'll ask each team to share at about 2:35 or so.
Also, listening, it's not just skimming her.
Not every time does a doctor or provider know like all the details that the patient might think right now, right? So establishing that contact. Also, right, is sort of communication, or sometimes someone goes in for a visit and they're talking with the nurse, and they're talking with the assistant. And the patient, if they're sure how much of that information is going on. Yeah. Oftentimes we'll get clarifying questions in the beginning to figure out, make sure that the information from the assistant is correct.
There's only so much they cut charts.
Yeah, yeah.
Maybe they could go and get this.
Yeah. And sometimes you gain the telephone a little bit, right? The patient shares the assistant and there's something kind of off there and has to clarify that. For consideration.
Unfortunately, I didn't, on that note. I won't try and be optimistic, and if it is something to do.
So if you already have your list, you have extra time, you might start to think about how you as a patient or you as a doctor could make those goals met, right? What could you do to make sure that that happens, how you communicate? So if a goal might be to make sure your issue is resolved or the injury is being dealt with, how could you make that happen?
Trying to know what's, trying to do something. It can't hang. Right, I could say, for the top shoulder. Check my.
Take a couple more minutes, make sure you have somebody from your group ready to share. Yes, the web and the survey. Yeah.
I did that once, my grade was.
Yeah, sometimes, like, sometimes you go in, like, the doctor will like, what you should say. I'm gonna tell you a diagnosis, I'm gonna tell you what you have. Don't look it up yet, don't go to your phone, take a moment to chat with you about this first. And then look back, right? So there's a lot of ways that, like, knee-jerk response, I wanna know what this is, I wanna know what this fact means, right? Sometimes lead the ways. There's good information out there, but it's a little bit challenging, especially in the very beginning. Figure out what is a good source. All right. So some good conversations that were happening from both of the teams regarding this whole process. So let's hear from each team from talking about what they see as really important to make happen in the visit. We'll use that to inform how we understand patient and provider communication. So let's start first with the patient perspective from team one. So for Candace, what needs to happen for her to have a good and successful visit?
So to put a clear explanation that is everything. So having the explanation. Getting her concerns addressed and that like leads to some input. And having the provider actually listen to them and also having like show up all the time. And another thing that is important is that her time got the necessary information that she wanted and needed.
Yeah. So thank you, Evelyn. It's interesting because I feel like there's a couple categories that your goals fit in, right? One of them being the feeling that your time is being used appropriately, right? If it's a super short visit or you're out for a super long time, that can feel disrespectful. But at the same time, we know from last week, we discussed with history, that more and more, right, we have a larger number of patients, and so doctors are having to jump between patients at a much faster pace. That's been accelerated even further with COVID-19 and the emergence of telehealth and remote appointments too, where like in an average day, there are a ton of back-to-back appointments that doctors are being booked with. So sometimes, on the flip side, right, doctors will feel frustrated if they feel like the meeting is going longer than it needs to be, and they feel like they're not able to meet their goals in the time that they have because they're constantly raising the clock, right? So there's this challenge there of finding. And also of feeling sort of respected and supported, right? I think that from the perspective of a provider or caregiver, there's this really challenging line to walk. If you're this like overly academic, detached, with using terminology and language so far outside of what a patient would know, that can feel really alienating and frustrating. But at the other end, right, if you're using like a baby voice to talk to somebody, you're talking really slowly or making the person feel like they're not intelligent or not a person, right? Then that can be a really big challenge too. In fact, one thing that women with disabilities, people of color have reported is some of the challenges of healthcare experiences has been the feeling that, especially if they disclose or share part of themselves that might have stigma attached to it, that they are taken less seriously or talked down to on the basis of that disclosure, right? So for some situations, patients might choose not to share or disclose information with a provider that they feel like could trigger them, right? So it's a challenge to walk in terms of feeling respected and heard, but not feeling patronized. Now, that's a thing we'll get into a little bit more in just a minute. How about on the doctor side? So what are some things that stood out to you all?
You said that, having compassion.
Mhm.
And then also just explaining the use of big terms. And then understand the background. So personal, know why I'm here,
Mhm.
and give options, establish context.
Yeah. So context is useful, right? One of the things that came up from this team over here that Garrett was mentioning, right, is that oftentimes, like we like to look up on the internet if you get a diagnosis or there's some health issue, right? We're like, oh, what does it say on WebMD, right? And one of the challenges is that while there might be some good and correct information on there, sometimes we don't know how to parse out the information or figure out its severity or the way that it impacts us, right? So providing context and saying, you do have this diagnosis, especially if you're navigating really uncomfortable terrain like a cancer diagnosis, right? You have this cancer diagnosis, here's the stage that it's at, here's what it means, and here are the options available to you, are the things that really help to, provide context, right? I don't know how many folks have watched the TV show Breaking Bad, but there's a scene that really stands out to me. I'll probably share it next class, where in the very first episode, right, Walter White gets his like cancer diagnosis, and the way that the scene is shot, right, is he gets his diagnosis, and then all of a sudden there's like this ringing sound, and the voice of the doctor fades out, right? Like he is just like fixated on this diagnosis and like totally distracted. And sometimes that can happen, right, when there's shocking or surprising information. And I thought it was a really interesting visual representation of the kind of dissociation that patients can feel. And also, as you all brought up, right, making sure that you, as a provider or caretaker, have the context that you need. One of the things we talked about on this side was this idea that sometimes it can feel like a game of telephone. When I went in following a car accident, I felt like I was sharing the same story and situation with people over and over and over again. And had to share to an assistant, had to share to the doctor, had to share to the receptionist, right? There's like this chain of communication that happens. And because things can be lost or misinterpreted in translation, one challenge for a doctor is to come in and perhaps start things out, provide the clarifying information that is needed to actually understand the person's needs, right? So all challenging things to think about. And I appreciated the way that both teams started to think about the crucial goals and things that need to happen for good patient-provider communication. So I think that there's a few things that characterize what a good process of communication looks like. Again, thinking about patient-provider relations and communication as a relationship, right? Whether you're getting into a nursing or related field yourself, whether you're somebody who is just interested in improving your communication, if you're seeking help here in the future, I think there are a few things that are crucial. One of them, of course, is trust, right? Trust comes from ethos, it comes from credibility, it comes from seeing a professional who knows what they're talking about, but it also means having trust in patients, having trust as a patient that what you're experiencing is real and needs to be talked about, right? As a personal example, when I was very young, right, my mom had a really severe pain and trusted that she had that pain when people were telling her, oh, we'll just get you touch this all the time. Turned out she needed to get her gallbladder removed, and if she could go in time, she wouldn't have made it, right? So oftentimes, patients have what they consider to be specialized knowledge about their bodies, about what they're experiencing and what's happening with them. That a good provider needs to take into account and consider. Clear communication is really important, especially as we'll talk about in a class like this one, right? There needs to be good communication on both sides. That means figuring out how to advocate for and share what you're experiencing, but also recognizing that you can't get it quite right. And then on the side of a healthcare provider, right, it's the idea that you as a provider are able to share and again, navigate that tightrope, not too patronizing, but also not too overly complex and abstract either. One of the challenges, right, is that as a provider, you do not have a firsthand account or experience of what that person is feeling. There's an episode of Black Mirror that I think is kind of interesting. And in the episode, there's a new like technology that's developed that lets a doctor like actually feel what the patient is feeling, right? And as it's depicted, of course, in the show, it goes off the rails, but when it's starting out, right, it helps the doctor understand what the patient is feeling, is actually able to diagnose the patient way easier because they have like this firsthand account. We don't get that in the world, right? We have a lot of situations where people are trying to share what they're feeling, but don't have the same terminology in a medical way to describe their experience. And so trying to parse out or translate that is the process of that communication too. Understanding expectations, as you all brought up. What do you want out of this? So for Candace, it means figuring out what this forward heading is. It might mean a short-term solution, such as medication that will help to navigate it, but also means an assurance that it's not an incredibly serious issue and figuring out and identifying the costs. That oftentimes is a really big driver for patients that come in for a specific reason. Expertise, as mentioned, is important. It ties itself to trust that the person we're talking about is an expert in their field and does know what they're doing. And lastly, this idea of respect. A lot of you brought up this idea that we should be empathetic and considerate and thoughtful of patients from a doctor's perspective. Absolutely true and correct. And it's also true that a lot of health providers are navigating and juggling a ton of patients and also experience severe burnout from that process too. And especially in the context of COVID-19 and a lot of frontline workers who have been navigating that as well. So it's a difficult line to walk, like keeping your level of empathy and care while at the same time having to deal with a lot of people. So when it looks when we look at patient-provider communication, right, it's looking at, as we've talked about, the interpersonal dynamics, the one-on-one example that you all looked at with Candace and the doctor. It's also about group dynamics, again, especially as it relates to rare diseases or navigating things such as cancer, heart disease, or more complicated issues. Oftentimes you'll have a health team with multiple experts start to develop, right? And as you could probably imagine, that brings in its own set of challenges when it comes to each person figuring out their role and, not overstep. It's almost like, like on shows like Queer Eye, right? They have each of the people on the show who does a different role, right? So one person is part of the makeover, does the fashion. One person helps with like healthy food. One person does mental health, right? In the same way, oftentimes a health team is establishing certain roles. One might be a nutrition expert, one might be a chemotherapy expert, one might be a physical therapy expert, one might be a counseling or mental health expert, and so on. So that can be great, but it can be a challenging network. And then thinking about power, authority, and listening are also really big issues, and navigating the dynamics of power effectively. Right? So power, right, is one really big thing that impacts our interactions. Because on the one end, right, if you're a patient and you're seeking out care, you have specialized experience to what you're feeling and experiencing. You know your body, you know things about your body that you have felt in the past and currently, and especially when we think about differences as they relate to gender, culture, and other aspects of experience, right? We at times might run into providers that are not experienced in the ways that we are. For instance, there are some people who strongly prefer working with a doctor who might occupy similar sex assigned at birth or a similar identity to them and feel greater comfort in doing so, right? Oftentimes, we assume if we're a patient that the provider is the person who has the power. This has been the model of physicians since kids, right? Oh, here's your diagnosis. But we know now that a lot of times that's not how things go, especially in the biopsychosocial model, and especially when thinking about the idea of what health means. It's very different from different people, right? We've moved away from that model in a lot of different ways to help patients think about themselves as active participants. We also know that physicians or providers might be prone to talk. And generally speaking, who occupies space and who talks is pretty closely associated with power. A lot of the ways that our interactions might go would be, here's a short description of what I'm feeling, and then a long response from the provider who's discussing or diagnosing the issue. In contrast to that, right, there's this idea of power share, that health information is conveyed from a provider to a patient as partners. So when you're navigating something like a cancer diagnosis, right, yes, a doctor can figure that out and parse out the information, can use x-rays and related material to develop an understanding of what's going on with your body, right? They can provide that information, but as a patient, somebody can decide what they see as the best approach. Are they going to actively and aggressively seek chemotherapy, or are they going to focus more on comfort and well-being? Of course, one of the challenges that comes in all of that might be if you are making decisions on behalf of somebody else. How many people are familiar with the Terri Schiavo case? Heard that case. So this was an incredibly controversial case that occurred during the George W. Bush administration. There are probably similar cases that we've heard about since then. But it was a case in which somebody suffered and was basically living with basic IVs and surviving with a ventilator. And there was a question as to whether or not they should go forward, right? And there was a pretty major kind of national discussion, battle, and all of that related to the decision whether or not to do so. Is that person alive? Are they coming to, or are they in this permanent vegetative state? What are the ethics or challenges of making that decision? And Terri Schiavo could not do that herself, right? That was a decision that family and those surrounding Terri Schiavo had to make. And that can be a challenge, especially when somebody does not necessarily have a living will or oral declaration of what they would do in that situation, right? So that can be a challenge too, is not only considering the relationship between the patient and provider, but what does it mean if a patient does not necessarily have the autonomy or ability to speak in that moment? So, right, one thing that physicians will often do as part of power is to ask patients to complete directives. Take this medication, come back and talk to me in a week if you're feeling any more symptoms. Common example. But physicians will oftentimes try to draw a line somewhere, especially if they want a particular health outcome to happen. You're sick, you have COVID-19, you need to be under quarantine, right? There's also this idea that sometimes the provider will do from a constructive place, known as blocking. We know that the provider has very limited time, resources, and once we keep the conversation direct and focused, they might choose to steer away from conversations or topics that are irrelevant. You're seeing an eye doctor and you're suddenly talking about a knee injury, right? Blocking might be used for the eye doctor to redirect the issue in question. Sometimes there is patronization, right? Again, talking down to or treating the patient like they are not a full human being. And then there's this issue of transgression, right? Sometimes what a doctor says or does can go beyond what could be considered appropriate or expected or wanted communication, right? Sometimes that can be the use of things such as physical touch. Sometimes that can be related to gender and issues of comfort. Sometimes it's about asking questions or sharing information that a patient doesn't feel comfortable disclosing or sharing about. For instance, questions that might not seem relevant, like sexual history, in doing like a general physical examination. But I think what's good to know here is that neither a patient nor a caregiver likes a lopsided conversation. For a patient, right, it's good to feel like they can actively participate and be heard throughout the process. From a caregiver or provider, it's also important that they feel like they're able to get what they need shared and allow the patient to convey their needs, right? A caregiver wants to feel like they are hearing out and supporting the patient in the specific needs that might be coming up for them. So all important considerations when we look at power and the relationships that we have with our healthcare providers. So with that stuff in mind, let's take a bit of a break. So it's about 2:53. So you're welcome to come back at about anywhere between 3:03, 3:05. We'll get started again about 5 minutes after 3 and pick up where we left off in patient-provider communication. Take a step outside and see what's going on with this weird thunder, rain, sun. I mean, it's an Oregon day, I guess. Yeah.
Oh, that's yeah. Oh, okay, so yeah.
I didn't read it. I like, that's the one that I went to the afterwards because I did it to like maybe. If that's the one I'm thinking about, I don't know.
Oh, thank you. All right. So let's come back here as a group and pick up where we left off, talking about patient-provider communication, some of the challenges, including power that can impact that relationship. We'll spend the remainder of the class going over some ideas, including models and general tips, and I'll give you a short activity to work on that'll let us think about how we can apply and use this in the context of doing motivational interviews. So when it comes to navigating power, one really important consideration that we have to think about is what people choose to disclose, right? If you're a patient, there's a lot of factors that might impact how you choose to talk about your health and related issues. For instance, when I did interview research, looking at people with disabilities, or members of LGBTQ+ community, one thing that they commonly told me was that disclosing or sharing a medical diagnosis or disability to a doctor, one interview described it as kind of like a duty free, like you disclose or share diagnosis, and sometimes the provider latches on to or gets excited about or focuses on that, and you say, but that's not the thing I wanted to talk about. That's not the concern I had. I was sharing that for your information, right? Again, things like bias, stereotypes, and maybe even context are important too. There are some situations, again, if you're talking to an eye doctor, where disclosing and sharing an irrelevant condition to what the eye doctor is looking at is not good for your communication overall. So it's a challenge for us to think about how we might disclose and share health information. And one model for doing so is what we can consider the disclosure decision-making model, right? This model has 3 different steps. The first being what we see as the predicted outcome. So let me give you one example. A lot of times, folks that might have mental or cognitive differences and disabilities in adulthood that were not caught earlier in their lives have articulated challenges with receiving a diagnosis and getting care. For instance, receiving something like an ADD or ADHD diagnosis could be useful for somebody to get resources and support that might help them if they're taking classes to get formal accommodations, right? So maybe somebody sees a mental health specialist or therapist under the predicted outcome that they would receive an ADD or ADHD diagnosis and therefore be able to receive care. They get what they would consider to be an anticipated reaction, right? That is, that they feel like they would be able to get a doctor or professional who would diagnose them with the condition and then provide them with the resources and information that they would need going forward. However, another important part of that is that the person disclosing or choosing to care for the provider has to feel like they have the confidence and skills to seek out the care or support that they particularly need in that situation, right? Another example, and a topic you're interested in it for your antigen bibliography, is the whole field surrounding cosmetic surgery, plastic surgery, and related fields, right? There are a lot of cases in which people will seek out those kinds of surgical procedures if they feel like they have confidence, awareness, and understanding of the risks and the process involved in doing so, and recognize what they would need to do in terms of care following them, right? Or even looking at it in other instances, something such as getting a tattoo. Oftentimes, if somebody chooses to get a tattoo, they want to feel like they have the confidence and skills necessary to take care of it, especially in that immediate period where it can be especially sensitive and vulnerable, right? So the disclosure decision-making model suggests that for patients who are agentically choosing to seek out care, they have to feel like they have confidence and they're essentially rehearsing in their heads how they think that the interaction will go. And sometimes it can be completely unexpected, right? Somebody expects a particular diagnosis, like Candace comes in for the headache, and it's revealed that she has a totally different condition that she's not expecting at all. So a patient can't necessarily predict the outcome from an expert, but they can start to put together some ideas and get the confidence to clearly articulate what it is that they're feeling or experiencing that provider can work with. So there's space for wiggle room, right? As a conversation, but the patient does feel a level of confidence. In this way, this idea then suggests that, as we've been kind of discussing over the course of the class, that good health communication is not just a doctor saying, here's what you have, take this, or you have this condition, you should do X, and it's not the other way around. It's not a patient bullying or bossing or telling the doctor what to do, but it's a collaborative approach that involves them essentially being peers, right? One way to reframe and rethink about health communication is to think about it as that you are peers or equals on the issue of your health. You both care about and are concerned with your health, though you're coming at it from very different perspectives, right? And I think that that type of reframing is a good way to ensure that communication goes better. That both you and a provider ultimately want you to do well, whatever that might mean. And the process of figuring out what it means to do well is something that you can figure out through your communication, right? Maybe for some, health means active and aggressive treatment and care. Other times it might mean focusing on living with, not necessarily curing a condition, and doing best surrounding it. So under a model of collaborative interpretation, which is a good approach for thinking about how to do health communication in this relationship, we focus on patients who are decision makers and problem solvers, right? They are the people who ultimately decide what to do with the options that they have available to them, right? And figure out what they want to do with their own bodies. Whereas, right, caregivers, whether it be doctors or other types of practitioners, or counselors or friends who help them to achieve those goals, right? In this way, a doctor or caregiver provides expertise on the information and options that are available to somebody. Here are the medications that you can take. Here are the things that we can do together. And ultimately, the patient gets to figure out what they want to do for themselves, right? Now, obviously, there are critiques of this framing and approach, right? It does put caregivers in a more passive role than we might expect. There are some situations where sometimes we want more actively involved caregivers, but I think this approach helps us to understand where autonomy and the empowerment of a patient comes in. Sometimes a doctor really strongly wants something like a surgical procedure done, but perhaps due to the culture or religion or background of the patient, they're uncomfortable with that procedure, right? So that's an important consideration in this process too. And there's also an important consideration surrounding issues of public health, right? Of instances in which the decision made by the patient does not just implicate the patient, but can implicate other people, right? And that's where I think a lot of the messiness and challenge surrounding discussion and discourse surrounding COVID-19 vaccination has come into play, where issues like these, right, can definitely involve this sort of shared approach. But what does it mean when it also has larger, more public impacts as well in terms of COVID-19 and so when it comes to thinking about making this positive relationship, one way of thinking about this that we talk about a lot in communication studies is this idea of framing, right? Framing not just in what you say, but in how you say it. For instance, the used car salesperson tells you to buy a car, and they say, hey, this car is really reliable, it gets good gas mileage, you know, the brake is a little bit wonky, and there's some tear on the inside, but it's still worth getting. That's a lot more persuasive than a used car salesperson saying, hey, you should get this car. The brake doesn't work, and it's ripped on the inside, but it's reliable, right? How you frame or choose to share information is crucial. How you say it matters. In this way, how we choose to talk about health, regardless of your perspective, maybe as somebody who's entering the health field or as a patient, is really important. Oftentimes, if we're focusing on outcomes, right, we're not necessarily focusing on a specific medicine or action that should be taken, right? An outcomes model instead says, if our goal is health and fulfillment, if our goal is to help a person to feel comfortable, to feel cared for, to feel wanted, what are we going to need to do in order to get there, right? What medicine or other related options help us to reach that goal, right? So for instance, when my sister and I took care of my father in hospice, right, one of the things we had to figure out was what for him could be the best in terms of health and fulfillment. We decided to do that at home because we felt like that environment would be an outcome that would better promote his health and well-being, feel more comfortable there than being on a hospital, right? Another issue that's important is this idea of maybe even reframing what a patient is entirely. Instead of being a patient, maybe somebody is a health citizen. That can be an interesting way to reframe or discuss something, right? The idea here that it's not just about answers, but that it's about solutions is another important idea. Oftentimes when we're seeking out care and trying to create a good relationship, it's not just about figuring out, do I have this? How long do I have? Like, you know, when it's dire, right? It's figuring out instead, given these issues, or given this diagnosis, given these health problems, what can we do? So solution mindset helps a lot. And then lastly, this emphasis on dialogue, that good health communication is a conversation toward a good outcome. It's not a one-sided, here's what you have, figure out what to do, or here's what you have, here's what you should do, but that the conversation creates a good relationship. And this brings us to a model known as patient-centered care, right? And I want to share a short video. There's actually a lot of videos that come from experts in health who actually provide like training for health practitioners on how to communicate with patients. And I wanted to show one that shows this patient-centered model. Because patient-centered care, again, is really focusing on decision-making and power on the individual in making choices that can promote their well-being. So as I share this clip, I want you to kind of pay attention to the ways in which this clip uses a model focused on the well-being and health of the individual and their
Yes. Heard from your doctor today. We just want to do something. Did you from the family or? Looks really bad. Is there anything else besides your headache that you have addressed here today for clinical?
No, just that, except I am concerned, I just recently changed insurance companies and I'm not sure this is gonna be covered yet.
Is there anything, because what we can do is while we're talking and I'm doing history physical, I'll have the office secretary that can do the insurance plan and that,
Alright,
so you don't have to worry
yeah,
about
that sounds good.
that. And is there anything else?
No, this is just really bad.
Okay. So what I'd like to do today is, let's take a look at what's causing your headache. I'm gonna go over history physical,
Okay,
and then we'll do our kind of physical exam. And then we'll look at your insurance policy and make sure that's all.
okay,
you can take care of that.
yeah, that's good.
Perfect. So tell me a little bit more about this, the head pain. that you have.
Well, it started about 3 days ago and, nothing has helped. It's just laid me flat. I, haven't been able to go to work. Nothing's helped. It's all over. It's really bad when I move, so I'm trying not to move too much, and the light is bothering me.
And unfortunately, I can't dim the lights
Okay,
in this room,
Alright.
but,
it's
so
okay.
I'll try to go quickly and, is it okay if I took some
Oh,
notes?
sure, yeah.
Alright. So you said this headache started about 3 days ago?
Yeah, mhm.
Okay. Was there anything that brought about anything unusual that happened?
Really, no.
Can you tell me anything that makes it better?
Nothing's made it better. I took some Tylenol, I tried Motrin, nothing. I just try not to move too much.
All right. Is there anything that makes it worse?
Yeah,
Like,
movement, and light.
okay.
And, it's just constant though. There's, it's just constant. It's all over.
So if you had to rate a pain scale, 0 being no pain, 10 being the worst pain you ever had.
It's a 10.
Okay.
I've never had a headache like this.
Okay. Yeah, that sounds really bad. Now as far as radiation, does it move? You said the pain is all over.
It's kind of all over.
Okay.
But it also, I've got this shooting pain down my neck, and my neck is very stiff. But it's not, it's the entire head.
Okay.
Yeah.
As far as in the time that you said that, so you said it's constant.
Yeah, it started gradually, but once it got there, it hasn't gone away. It doesn't get better, it doesn't get worse, it's just the same.
So what I want to get is your perception of what you think is going on.
Just, I can hardly think, it's so painful. I just, because it's so bad, I was afraid, my neighbor, had it and ignored it last year, and, suddenly started having seizures, and it turns out he had a brain tumor, so my God, I just should come in and. Yeah.
So it goes on a bit longer, and toward the end, the doctor starts to provide some guidelines or advice on what the patient might do and medication that might be taken in the short term. But I'm curious, based on watching the video, what were some things that stood out to you on communication, maybe from either side? What did you notice from the patient or from the doctor about the ways that they chose to talk about that headache? Yeah.
She asked like her perception of what it could have been caused by, and then she asked to describe it to her. And show her.
Yeah, I really, I'm glad that you caught that because that's an important way to frame it. And I think is a really good example of walking that line, right? Where you're not saying, well, you're wrong, here's what I think it is. And it's also not saying you're 100% right, what you feel is like totally what it is, you have a brain tumor. That would be irresponsible of the doctor to assume that she had a brain tumor based on the story about her friend, right? But the thing that's really appropriate in the middle is the doctor asking the patient's perception of things. Something that stood out to me too as I was watching is that the more that the open-ended questions were used and the patient was sharing, like the more detailed and specific the patient got in her experiences surrounding things. She started to talk about the pain going down her spinal cord, which is something that was not shared in the beginning, and that openness allowed the patient to share more detail that would help the doctor make a more informed decision about care. There are other things that stood out to you all in terms of that conversation, things that you noticed. Yeah, Garrett.
And the doctor immediately went to your insurance concern, like, for us, cover that immediately, so we didn't have to worry about that throughout the visit.
Right. Anybody who has had to deal with a medical bill in that process knows that insurance can be an absolute pain, right? Navigating insurance, figuring out who will accept your insurance, figuring out networking, out of cost deductible, like it's a painful, messy way. And oftentimes that fear is something that can just completely impact and distract from the conversation with folks, right? One thing that I think that the doctor does really well in this case is anticipating patient needs, right? Saying, I know you're going to be worried about insurance, can't solve it right here and now, but we're going to get something on it. So by the end of the session, we've got it figured out, right? There's also the bit about the lights, right? And if not being able to turn the lights off. Part of me, as I was watching this, was thinking like, you should just offer her like a pair of sunglasses or something that would help to manage the lights too. In a lot of health situations, they'll do that if they can't actually dim or change the lights. Although if she was trying to track and figure out things like eyesight, potential for blood around the eyes, I guess it would have been important to make sure that the eyes are visible. Any other things that stood out to you all or things you noticed? Yeah.
A small detail, but to go along with those, Dr. Ginsburg.
Yeah.
Talking, you see that she was still staying there.
Yeah. So the nonverbal communication is super important. We're actually going to hit on that in a minute, but the way that using eye contact, using focus, engagement, you probably felt yourself and your experience is really important. So all kind of examples of that patient focus model that again doesn't suggest that the patient knows everything because they're seeing the doctor, they're an expert, but ensures that it's open-ended. And one of my favorite analogies is I think it's like a children's story or myth. It's about the sun and the wind have a fight over who can get a person's coat off, right? The wind says, well, blow it really hard and the person's coat will just fling off, and the wind blows, right? And the person just bundles their coat up and zips it up more, right? The sun comes out and just kind of shines and the person takes off their coat naturally. So the sun wins, right? And in the same way, we were thinking about patient-provider communication, being open-ended, being supportive, not forcing, but instead opening up to questioning, let the patient share more and more, maybe feel more and more comfortable. You start to tease out, in this case, the patient's really concerned about the friend who has a brain tumor. Obviously, is not qualified to say whether or not she has a brain tumor herself, but now the doctor knows that fear is in the background and is implicating the way that the patient is interpreting and making sense of this headache. So all examples of how the patient-centered model can be used in practice. So one of the important ideas here and something that came up over this conversation is this idea of motivational interviewing. So an interview, right, where you're asking questions, maybe you're working through an intake form or trying to get information related to the patient, is a strategy to guide people toward behavior. A motivational interview is unique in that it's focused on trying to guide somebody toward an outcome, right? For instance, a motivational interview could be a conversation with a counselor when you're trying to decide where to go to college, right? It's figuring out what your goals are and using the interview process as a way of reaching those goals, right? So that might be medication, might be possibility of surgery, and so on. And for patient-provider relationship, figuring out things like work availability, flexibility, the availability of insurance, prior health conditions, and other issues would be really important things to resolve to get there. So setting a good tone, right? Using eye contact and respect, and showing understanding. Letting the decision maker set the agenda, right? Establishing, hey, you're here for the headache. This is the thing that you're clearly concerned about, and let's talk through it. Figuring out the decision maker's interest, right? So when you're thinking about possibilities like medication or surgery, have you considered this? Have you considered this? Are good open-ended types of questions to ask. Exploring ambivalence. So for instance, maybe the patient is hesitant about getting an X-ray. Understanding why they're a little bit concerned. Maybe they're concerned about the radiation involved, right? Might be a thing that you can check in with them about. Listen, elicit, provide, elicit is a good model. We kind of saw this play out over the conversation where the doctor was listening to what the patient was explaining, providing feedback and support, and continuing to do so over the course of the meeting. Figuring out multiple options or approaches is a good one, right? Helping patients figure out what the good option for them might look like. If you're familiar with cost-benefit analysis, it's the idea that we make a calculation looking at the benefits versus the costs of any action that we take. Partnering rather than persuading, right? Sometimes a professional feels really strongly that an action should be taken, but ultimately it is up to the patient to make a decision about their own health, right? If we think about the Hippocratic Oath, what is the Hippocratic Oath? Do no harm, right? Hippocratic Oath means that doing harm might be forcing somebody to a decision that they don't consent to. Additionally, rolling with resistance. For instance, if somebody is pushing back against or choosing not to share, it might be redirecting the conversation to a topic that they're comfortable with. It might be engaging in an affirmative way with people. How many people have heard about, and I'm going to mention something at the Oscars, it's not that thing, but the interaction between Liza Minnelli and Lady Gaga at the Oscars. So Minnelli, right, is older, as I understand it, is dealing with, I believe, Alzheimer's and dementia, right? And there is a specific way that at the Oscars, Lady Gaga was communicating with her that is meant to be affirmative and supportive. Said to her, basically, you've got this, right? And there's a common practice for people that might be dealing with conditions related to Alzheimer's, dementia, or schizophrenia, where you are not supposed to tell the person that their story is wrong or what they're sharing is incorrect, but instead to affirm or support them as people, right? So there are kind of vocabularies that have emerged about how you deal with resistance, right? Again, having also seen firsthand, navigating some of the ways that people with associated conditions encounter and share their experience, right? To them, it is true. To them, it is real. And so pushing back and saying, no, that's not real, you're imagining things, can be something that really disrupts. Confidence and self-efficacy, right? Doing something like rating on a 10-point scale, how bad the headache is a great way to help the person feel empowered. Focusing on small changes, for instance, working through insurance could be an easy way to get the foot in the door. And then collaborative approaches, as we've mentioned, are important too. So getting further on some of the things Patrick mentioned regarding developing good interpersonal communication, particularly when it's face-to-face, right? Oftentimes we use nonverbal communication for important cues. In fact, a lot of studies suggest that nonverbal communication can account for 85% of communication overall. And we attribute more trust to what we interpret from nonverbal communication than verbal, right? If somebody says, "Oh, it's so good to see you today," but they're rolling their eyes and they have a sarcastic tone, we'll read it as, "No, they're not read it based on their words." So nonverbal communication on both sides are really important. Looking interested, if a provider seems bored or disengaged, that is a really big concern from the get-go. The use of touch and physical contact is generally something to avoid except when absolutely necessary. Of course, allowing silence, especially when a patient is dealing with a difficult or personal issue to process and understand that is important. Paying attention to nonverbal communication is important too. How does somebody choose to share or respond to information they have? And the interaction we saw, right? Somebody's touching their head, they're feeling that headache, you can tell that they're hurting, and that matters. Starting in a friendly and positive way. Oftentimes, patients are eager to get out of it. And so helping to expedite and make the person feel like they're an ally that can get through the issue together is important. Full text matters, as long as it's not distracting from overall care, right? Don't get into a long side conversation, especially if you have limited time. Open questions, right? We're used here to describe the overall feeling of pain that the patient felt. Not rushing, giving the patient the time to share and really feel like their concerns are being heard is important. I like the flow of questions that the doctor used too, right? It was very much talking about this pain and evolving a discussion about the pain. Where have you felt it before? How does this compare to other pain that you felt, and so on? Was a really good strategy. A doctor has to make decisions, right? They have to figure out what is and isn't important. Maybe the story about the friend who had a tumor matters to that person, but those things aren't related. And the doctor knows that signs of a brain tumor are different from what the person is experiencing. A distress marker might be like that brain tumor story, showing a situation in which an issue is a really major cause for concern. Asking for feedback, right? You're probably bombarded with surveys after you do a visit or something similar, but giving feedback including in the moment, is this making sense to you so far? How are things going? Can be a really good way to make sure the communication is going well. Reassurance, as long as it doesn't feel unearned, like you're going to be okay, but it doesn't make sense in that situation is a problem, right? I feel like all of this, like nonverbal and interpersonal behavior, basically take everything that Gregory House does, if you've watched the TV show House, right, and do the opposite. You've seen it, right? In this show, he's very cantankerous and rude for bedside manner. Treat people like equals, right? The conversation with a collaborator. Coaching is helping to provide direct feedback to guide people toward an informed decision. Humor can be okay, right? Sometimes, especially in like a more pediatric setting, like working with kids, it can be great. Using levity when it feels earned and appropriate is important. If somebody is talking through a serious issue, does it make sense to use humor in that moment? And avoiding distractions. Again, the example of lighting was a good one about how to minimize those types of issues. A couple other things before I ask us to wrap up for today. There's this idea of narrative medicine, right? That oftentimes when we describe and talk about our experiences with health, we use some storytelling. We start to see that with the patient talking about their headache, right? We use stories to make sense of what we're feeling and also how we process and deal with health issues, with disease, with challenge, and the ways that it impacts our lives. We'll talk more about this later in the term when we look at disability-related issues. But there's a few different narrative frameworks that somebody could deal with. So, for instance, somebody has just been diagnosed with terminal illness, right? And in that situation, of course, that could feel incredibly jarring and tragic. And narrative medicine describes a few different ways that that experience is internalized and processed for that person. A sustaining narrative that this person is going to continue and persist on, that things are going to go as normal, as if they're largely unaffected, right? An enduring narrative that says that they are surviving or dealing with this issue that has been a huge blow to themselves, right? A preserving narrative that focuses on keeping positive experiences together. Maybe that person says, you know, I don't have a whole lot of time left, but I want to preserve and have the best experience with what I have. And a fracturing narrative that talks about the ways in which negative health experiences have fractured or broken up their overall self-perception. So in this way, right, oftentimes when somebody is encountering something like a disease, an illness, or condition that affects their lives, we incorporate it into the stories that we tell ourselves about ourselves, right? Incorporate it into how we narrativize and discuss issues of health. So before I have us do our last activity for the day, I think a few tips help us if you're a patient, right? If you're somebody that's in the process of seeking care, maybe you're about to go see a doctor or work with some professional in a related field. Some things that you can do are to take stock. Again, it was pretty clear from that interview that the patient knew what they were feeling and how bad they were feeling that day and where they were feeling. One thing, especially if you have a history with health, with illness, or just have a lot of context surrounding your health information, is to generate like a one-page document that's about your health history and related issues. So it's an easy thing to make your interactions more efficient. Some health providers even let you send your health history in advance. Writing down the ranking order of concerns, right? So one big mistake that we can make if we're seeing a doctor or working with somebody is to bite off more than you can chew. If you're seeing a therapist, for example, which we might put within the health communication umbrella, we don't tell them our entire life story or everything. Generally speaking, a good meeting with a therapist is focusing on a topic or issue that's important to us and really honing in on that topic, right? Depth and breadth. Preparing for standards questions about some of the practices that a provider might do. Choosing your providers. So oftentimes, providers will share a little bit about their background, their expertise, so on, where they went to school, and you know, their level of experience. That can be a really important consideration, especially if we're thinking about things like referrals. Not overlooking resources like brochures and other information that a provider could give. Know the treatment that you're supposed to get, and knowing that a provider is aware of that too is an important consideration. So essentially understanding if I have this, I need this is an important thing to share. Again, agenda connects well to the rank order concerns, making sure that you know. Talking to a nurse or to an assistant who can oftentimes provide that front matter context. Abusing the clock would mean like if there's something that you know is important and that you want to talk about and should talk about, but you decide to let time run out and oh, you can get to that. Putting it off like that can be disrespectful. Taking on an active role in your own health, of course, matters too. Showing your reservations, right? So saying, I'm a little bit uneasy about this type of treatment, or I'm a little bit concerned about this headache because of this brain tumor that my friend has. And then being assertive and being willing to say what your boundaries are, right? Oftentimes for a provider, it's a lot better to say, no, I can't do this, or I feel uncomfortable about this, than to just be kind of vague and say, I don't know about this, right? So those are some of the things that we can do to try to make a positive experience overall. So what I want to do now is, you know, you had the chance to see with that relationship elements of motivational interviewing. What I'd like you to do is to take a few minutes on your own. You can write or type this and turn it in for attendance for today. And I would like you to just think about a few types of questions that as a provider, you could ask for motivational interviews. So for instance, thinking about the way that the doctor asked questions about the level of injury or pain the person experienced, asking questions about where they felt the pain are examples of using motivational interviewing. What are the types of questions that if you were a provider, and you could use this in a lot of different situations, like general health, eye doctor, or therapist, and so on, how might you ask questions to ensure that a patient's needs are being met and thought about? So I'll give you the chance to brainstorm and write a few examples of motivational interview questions that you could ask as a provider. Take a couple more minutes on this. Examples of motivational interview questions you could ask as a provider. Take another minute or so to finish up. Anybody who wants to share any of the motivational interview questions? that they- CJ, what was one question you came up with for motivational interview?
So,
Yeah. So a goal-centered question is great because goals help to make sure that everybody is on the same side and understands what those needs are for sure. Kane, what about you? Mhm.
Like, if they had a headache or something, but, the patient didn't want medicine. But, I understand you don't want medication, I don't know. What other alternatives are you more comfortable with?
Yeah, so open-ended, what are alternatives that you're comfortable with is a great way to do that. And also to show like preparation that you understand those alternatives versus, no, you should take this medicine. Let me persuade you why you should take this medicine, right? That's an important distinction. Izzy, what about you?
I kind of started with the goal one, but then you start
Mhm.
and maybe just do, you know how they always say, what are we looking at today?
Oh,
Like,
yeah,
leading off of that,
yeah.
instead of Just like looking at questions,
Mhm.
like what are we looking at today, how am I helping you?
Yeah, how am I helping you is a great way to frame it too, right? Really helps to create that collaborative environment. So I really like these examples, right? And the ways that you all are using open-ended questions to create this motivational style of interview. And as we're wrapping up for today, right, we know that patients and providers face some unique challenges. A patient comes in with expertise about their own body, but not necessarily the vocabulary to talk about their specific experience. Provider has that vocabulary, but might not know the context of what's going on in that person's life. It's a matter of bridging those gaps and creating collaborative and respectful communication. Understanding one another, lending expertise and awareness, but not directing the specific outcomes. And we talked about how we're able to empower and help people navigate communication. For next class, we'll continue to look at these relationships, explore both from patient and provider perspectives, unique contexts and challenges that oftentimes people find themselves in with health. So go ahead and either email or pass forward the attendance activity that I asked you to complete, and have a great rest of your afternoon. Enjoy the rest of the day, whatever weather decides to do. It looks like there's some rain and stuff going on now, but it will probably be sunny again in an hour. So we'll see what happens. Have a great afternoon.